Hello, my name's David Jackson. I'm an ST5 registrar in NHS Tayside, and I was one of the principal investigators for the microwave treatment of actinic keratosis study.
Why did you do this study?
AK are a very common skin lesion. They are precancerous, and there's good evidence now that treatment of them can prevent skin cancer from occurring. It's very important, especially given the huge number of skin cancers that we're experiencing in the NHS. So we teamed up with a Scottish company, Emblation, who have developed a microwave that can be delivered to the skin using their Swift device. This was a first-in-man study to test not only the ability of the microwave to treat AK, but also the feasibility and acceptability of this treatment.
So how did you do it?
The first part of the study involved collecting data on the dielectric properties of 12 thick and 22 thin AK. This allowed us to calculate the dose of microwave energy to raise the temperature of the skin into the subablative region of 42 to 50 degrees centigrade. Following this, the second part involved 11 patients with a total of 179 symmetrically distributed AK on either the forehead or scalp or on the dorsal hand. They had their AK mapped on an acetate grid and up to 10 AK treated with the microwave device. The opposite side was observed as an untreated internal control. We followed up each patient weekly to observe the response to treatment and also collected information on how painful and acceptable the treatment was.
What were your main findings?
Well, we initially chose a 5-watt dose, but found that this was both painful and seemed to cause tissue destruction, suggesting it was ablative rather than subablative, as we'd hoped. We went back and adjusted the protocol, so thicker AK were then treated with 4 watts and thinner AK with 3 watts, and the treatment was delivered as 3 3-second pulses, about 20 seconds apart, to each of the treated AK. The treatment caused a sharp pain, but only in the final 1 second of each pulse, and overall was extremely well tolerated and often preferred by our participants to their previous treatments. At the 4-week assessment, if treated AK was still apparent, the participants were offered a second treatment, and 51 of the 93 treated AK received this second treatment at 4 weeks. 90% of AK showed a sustained response to treatment at 4 months, with thin AK showing higher response rates than thick AK, as you might expect. Interestingly, this treatment does seem to be as effective at acral sites as at the forehead and scalp.
Why is this study relevant to dermatologists and their patients?
Well, this is a safe and easy to deliver treatment, and it could be given by a nurse in a primary care setting and is quick enough to give when a patient is attending for another treatment or assessment. As a lesion-directed therapy, it will be much easier for the patient than using a cream, and it seems to be very well tolerated, which may improve compliance. Now, we do need to validate it against another comparator, such as cryotherapy or topical 5-fluorouracil. If it's shown to be non-inferior and cost-effective, then this may become an important skin cancer prevention strategy.